Okay, so let's start with hemodynamic monitoring. Erden is your critical care book. So that's chapter 10. And it's not the whole chapter, it's just those pages, 97 to 116. There's a little bit about hemodynamics in IGI, but not that much. So that's why I didn't put them there. Okay. So what are we going to do? We're going to try to identify and implement appropriate nursing action to care patients requiring hemodynamic monitoring. So we talked a little bit about this morning. So hopefully this is helpful for you for this presentation. So what is this fancy thing called hemodynamic parameters? Parameters are a bunch of numbers, but when we're studying hemodynamics, it's the forces involved in the flow of blood. Hence why we have that picture of that heart that I told you guys to pull out and bring to the lecture. So we're going to talk about different things and flow in the heart. So if you don't understand normal flow in the heart and what direction things go, I'd probably review that as well. So hemodynamic monitoring is an evaluation of cardiovascular function. And it's three things that we're going to measure. We're going to measure pressure, we're going to measure volume, and we're going to measure flow of the blood. Okay. Non-invasive, and I told my groups this morning that, you know, a simple blood pressure is non-invasive hemodynamic parameter monitoring. I'm sorry. Non-invasive is just getting a blood pressure and maybe assessing the strength of the pulses peripherally. And then we can go further into it a little bit minimally invasive and invasive, and we'll talk about those different ways to do that. Review your normal cardiac physiology and blood flow in the fundamentals book if you want, if you're struggling with that concept. So I just gave you the page numbers there. So I like this drawing, one, because it was given to me by a colleague who I worked with for many, many years, who's now retired. And she's a cardiac nurse. And she, when I started learning about the different things in the ICU, she gave me this. And I just think it's very, very helpful. Lorraine, what I want you to understand is our patients this morning had, you guys don't see the PowerPoint?
No, it's just stuck on the first one. It's not, yeah.
Cheers. That's weird. Can you see the heart now?
Yes.
Yes.
Perfect. I'm sorry. I don't know. Yeah, and it's hard for me to pay attention to chat. So if more people start chatting in there, I'll see it flash. Okay. So when we were talking this morning, we had that triple lumen in, or central venous catheter, whatever you want to call it. And the tip of the central venous catheter really dead ends in the superior vena cava. It's not all the way into the right atrium. And the only thing that we can measure from a triple lumen catheter is the right atrium pressure, or CVP. They mean the same thing. So if your patient has a triple lumen catheter in the subclavian, or IJ, it ends up in the superior vena cava, and we can measure right atrial pressure, or we also call it the central venous pressure, CVP. That's the only thing that you could get from a central venous catheter. If I have a SWAN, or pulmonary artery catheter, it is inserted all the way into the heart, and I'm going to show you a video in a little bit, through the valve, down into the ventricle, and then it goes up into the pulmonary artery and just sort of floats around here. So pulmonary artery catheter is through the right atrium, through the right ventricle, and up into the pulmonary artery. And then we get different numbers once we have that pulmonary artery catheter in, and I'll talk about those in a bit. We don't really do any direct measurement of the left side. Some hospitals put in, and this was years ago, I don't even know if they do it anymore, left atrial lines, which I've never had. I've never taken care of anybody that's had a line in the left atrium. So really, the only thing that you would think of where the catheter would be is down through the right atrium, right ventricle, and then it just kind of floats around in the pulmonary artery, okay? That's the pulmonary artery catheter, or also known as a Swan-Ganz, which is named after the two physicians who developed that catheter. So I use this and I draw on it. I got all kinds, mine has all kinds of writing all over it from years past. So I think it's helpful to have it out so that you can sort of, add to it. And then the one that's on Canvas, Stephanie uploaded, she actually put all of the pressures in there and the numbers in text boxes. So you can see that one as well. Okay, so preload and these other concepts, that's part of that pretest. So if you have your pretest nearby, I'm going to kind of talk about what those answers are. So preload is the volume of blood in the ventricles, the volume of blood in the ventricles. So anytime I think of preload, I think of volume. And remember, there's two sides to the heart. So we have a preload on the right and a preload on the left. And we'll talk about those in a couple slides. But we want to have this ideal amount of volume. In the groups this morning, I referred to a balloon. If we blow up a balloon and we blow it up, pretty well and not overstretch it, it has this beautiful contraction that allows for that air to kind of come back out of it. If I only blow it up a little bit, there's not much that comes out of it. So it's very weak. Or if I blow it up too much, it can overstretch. So we want that ideal spot, that ideal amount of volume in the patient. And we're going to measure that in a minute. But to answer number one, what is preload? It's the pressure or the stretch exerted on the walls of the ventricle by the volume of blood filling the ventricle at the end of diastole. I'll say that again, but don't panic about writing down the answers because I will upload them. Preload is the pressure or the stretch exerted on the walls of the ventricle by the volume of blood filling the ventricle at the end of diastole. Okay. Preload, volume. And that's why I have it highlighted in blue. Afterload is the resistance the ventricle has to push against to get that blood out of there. So when we talk about afterload, it is the resistance to ventricular contraction or systole. The resistance to ventricular contraction or systole. Pressure the ventricle has to overcome to open the aortic or pulmonic valve to push the blood out. Pressure the ventricle has to overcome to open the aortic or pulmonic, remember there's a left versus right, to push the blood out of the ventricle. Resistance. So, the more resistance, a locked door, we can't get through the locked door without the key. So the more resistance, the more pressure, the more work that the ventricle has to do to try to eject that blood. And then lastly, contractility. These three concepts all make up that stroke volume. So contractility is how well is that ventricle pumping? And something we talked about this morning is that ejection fraction that we see on a 2D echo will tell us how well that patient can pump blood out, can contract to get the blood pumped out of the heart. Okay. So back to your pretest. Preload is reflected in two measurements. That's the right atrial pressure. That's on the right side of the heart. And then the pulmonary artery occlusion pressure, or PAOP, that's on the left side of the heart. And don't panic because we're going to talk about it coming up in a couple slides. And then afterload, remember we have a left and a right again. So afterload, systemic vascular resistance is left-sided afterload. Systemic vascular resistance is left-sided afterload. And then pulmonary vascular resistance is right-sided afterload. And if you understand the flow of the heart, you know that it has to go from the right ventricle into the pulmonary artery. That totally makes sense. And you know from the left ventricle, it goes out to the rest of the body. So that's systemic. That's the way that I remember those. Then the stroke volume is the amount of blood that's ejected from the ventricles with each beat. And we'll get to what the normal levels are in a couple slides. So stroke volume is the volume of blood that's ejected from the ventricles. And preload, afterload, contractility, if any one of those are messed up or altered, it will affect the stroke volume. And if the stroke volume is affected, see, it's a chain effect. If the stroke volume is affected, the cardiac output is going to be affected. And the way that we get a cardiac output is we take that stroke volume number and we times it by the patient's heart rate. Now, I have to tell you, and I always make fun of Deb Phillips because she actually had to hand calculate all these parameters. I had a machine. I pushed a button and it gave me the number. So that's beautiful. But theoretically, let's say that the patient's stroke volume is 60. And we times that by their heart rate of 60. So 60 times 60 is 3,600. I hope I'm right. So the cardiac output is 3,600 milliliters, or we call that a 3.6 liters. We talk about the cardiac output in liters. That's how they would calculate. And that's from Stephanie's other page that has the big boxes that say cardiac output, cardiac index. Okay, we report them in liters, but you have to calculate them and convert them from milliliters to liters. Okay. So cardiac output is the amount of blood pumped by the left ventricle to the entire circulatory system each minute. Okay. Product of heart rate and stroke volume, which we did. And your normal cardiac output is 4 to 7 liters. 4 to 7 liters, okay, per minute. And we'll talk about why it would be decreased versus increased in future slides. So that number, yes, and I told the students this morning, yes, you do have to memorize. Yes, you do have to memorize these numbers because you have to know when they're abnormal and what to do about it when they are abnormal. Okay, stroke volume, we just talked about the amount of blood, each contraction, each beat, 50 to 100 mLs. Doesn't seem like a lot, does it? So 50 to 100 mLs. Okay, and then you times that by your heart rate because it's each beat. That's how you get the cardiac output. So we talked about those factors that influence the stroke volume: preload, afterload, contractility. And if any one of those are altered, you're certainly going to have an alteration in the cardiac output. Now, cardiac index is a much more specific and individualized way to know what's going on with the patient, because it factors in the patient's body surface area. And again, I don't do this by hand calculation. The monitor does it for me. So the cardiac index is definitely, anything that ends in index, by the way, you guys, is more specific to the patient. Because let me tell you this, all of us here could have a cardiac output of, let's say, 4. But my index might be low, even though I have a cardiac output of 4. So it's really individualizing and really saying, based on my body surface area, that this cardiac, the index is not good, okay? So it's important that you understand. I mean, we talk about cardiac output all the time. It's a very general kind of thing, but the index is way more specific to what's going on with the patient. Just another diagram. I'm a visual person. So if any of these are altered, it will affect the stroke volume, which they're avoiding. And it's just a downhill trickle. Do you see that? If one of these are altered, it's going to affect this, then it's going to affect that. So if I have a preload that is severely altered, your brain should say, so should my cardiac output be, okay? So you can see it's a trickle down effect. If something's messed up at the top there, it's definitely going to affect all the way down to the cardiac output. All right, so let's talk preload here in a little bit more detail. So we already said pressure, stretch exerted on the walls, and that's the answer to number 1. Typically used as an indication of volume status, okay? So if we want to know if somebody's fluid excess or fluid volume deficit, we're going to use the preload, okay? And this is my concept of the balloon, and that's a swimming pool to the right. So when I think of preload, I think of a pool, P-O-O-L. Is the pool empty or is the pool overflowing and the water spilling out? So if the pool is empty or down, it has too little preload. And if the pool is overflowing, it's too much preload. So you can see how it affects, and you don't get that contraction that you want. Remember, you want to be in that sweet spot, okay? So you don't want too much preload and you don't want too little preload, okay? Afterload, right? There's a question, I think. I can't see. Sorry, I can't see the chat. Well, I'll
No,
pause.
it's
wait.
Lorraine, I'm here. I'm sorry.
Go ahead, say it.
There's not a question right now.
Okay, thank you, Jill. Thank you so much.
I'm popping in out to check it for you.
Thank you so much.
Sure.
Thank you. Okay, so afterload, and I have the pipes over here. So this is the pipes, so the resistance. And I told my groups today I'll have to put my video back on. I'm sorry. Let's see. Let's find. Oh, I got to admit somebody. Hang on. Boom. All right. So ideally, your afterload should be this straw. Okay. We have just enough tone to maintain blood pressure and all that fun stuff. So normal afterload should be this straw. Okay. Now, when we start having problems with the afterload is when we either have too much or too little. So when we have a low afterload, a low or decreased afterload, if you can see this is toilet paper roll. Everything's flowing through there. The pipes are wide open. Everything's just dumping out. Okay. When we have too low of an afterload, that means we have absolutely no tone in the vessel. Now I lost my coffee stirrer here, but the coffee stirrer, very, very narrow diameter. So the coffee stirrer is like vasoconstriction. So very, very tight pipes, maybe like a pipe that's got a lot of calcium buildup in it. You can't get flow through it. So it's harder to get the water through the pipes. So clogged up pipes, very, very tight, very small diameter. The coffee stirrer is vasoconstriction. The toilet paper roll, vasodilatation. Everything's dumping out of this. It's wide open. We want to be the normal straw. Okay. We want to be the normal straw. All right. Okay, next. Last determinant of that stroke volume is contractility. And I was telling the groups this morning that we need to look at our ejection fraction on our 2D echoes. So that should be one of the first places that you go if you're really worrying about somebody's contractility, is looking at the ejection fraction and how well that heart is contracting. So is the heart able to squeeze and contract and get that blood out of that heart? Or is it a very, very weak? See how the flow is coming beautifully out of this pump right now, and this is the pump. So when we think of contractility, we think of the pump. Pipes were resistance. Swimming pool was preload. This pump, if it doesn't have enough volume to pump out, it's going to have a smaller stream, right? And if it's clogged, you're going to have to press down that handle very, very hard to get that blood out of that heart. So it's working way harder because it's not contracting as effectively. So contractility is an important factor as well. And we'll talk about some medications that can help with contractility. Now, please, 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 let me say that one more time, please, do not memorize this slide. This is just an overview of things that we can do to do hemodynamic monitoring. And if you look here, I'll just point out a couple that we're going to talk about today. This bioimpedance, that's one that we're going to talk about. That's a non-invasive way to get hemodynamic parameters through the chest without sticking a catheter down in through the heart. It's a non-invasive way to get cardiac or hemodynamic parameters. You'll see an arterial catheter quite often inserted, either in the radial, brachial, or femoral. Femoral is dirty. We try not to go femoral, but during a cardiac arrest, we go with what we can get. And then and this is CVC, where we can get preload, we can get right atrial pressure here. Don't worry about the SCVO2. That's something else. And then most invasive is the pulmonary artery catheter, or SWAN. Okay, that you'll see when you go to Deb Phillips's unit for the open heart patients, because we want to know minute to minute how that open heart patient's heart is functioning. So those are the ones that we're going to talk about. These other ones are different ones out there. I've never did the Dopplers, esophageal Dopplers, or any of that. So this is a transthoracic echo. That's a TEE. So we're looking at, and I think it's invasive because you put a scope down somebody's throat to take a look at how well that heart's contracting. But we'll talk about bioimpedance. We'll talk about the art line. We'll talk about the CVC catheter getting right atrial pressures. And we'll talk about the pulmonary artery catheter getting the full set of hemodynamic parameters. So this is the one that I kept saying that you'll probably see more often than not. It's called impedance cardiography. And on the left side of the chest, they have, that's the left side. On the right side of the chest, they have patches that match. So think of on this side that he has a set over here as well. So there's 4 total. And what we can do is we can get, we can measure flow. So stroke volume index and cardiac index. We can measure SVR. And more often than not, we use it for determining whether a patient is responsive to fluid. We don't just go, well, their blood pressure is low, let's give them a bunch of fluid. Because if they're not going to respond to us giving fluid, why put them in heart failure and give them too much fluid? So we do a test, which I'll show you in the next slide, that we can determine whether they're going to be fluid responsive or not. All right, so how they do this is called the PLR, the passive leg raise test. So they bring this machine in the room and they hook them up. So you see the 4 patches. And then we have them right here. This is the baseline. They're sitting in a semi-Fowler's position, and we take a set of numbers. We take a set of numbers. And then what we do is, do you see this here? We flip them down into a supine position and lift their legs. There's actually a pillow that comes with this that puts them at this angle. And they want to see if there's a change in the stroke volume index. And they do these numbers. And if that, and it calculates it for you guys, so you don't have to like do crazy math. If the change is greater than 10%, you know, if the change from my sitting position to my challenge position is greater than 10%, they will be responsive to us giving fluid. If I do this and they have a 7% change, they're not fluid responsive. So this is not a patient that we would give fluids to. I hope that makes sense. So let me say that one more time. We get a set of numbers at baseline. The numbers come on this little machine right here. Then we put them in the challenge position and we get another set of numbers. And if it's greater than 10% in those numbers, we give them fluid because they're responsive to us giving fluid. If the change is less than 10%, we say, forget fluids, we need to do something else. They're not responsive to fluids. All right, so I'm going to stop sharing here for a second.
In Dr. Colmer, I did receive a message. I'm not sure if you got this as well, but I will
Talk
read
a little
it.
bit louder, Joe. I can't hear you.
Oh, sorry. So I did receive a message from a student. I'm not sure if you got it as well, but they're asking, what if you have a high preload and a low afterload? Okay. It says if the it affects the stroke volume, allowing more out ? So that would cause edema ? Things like that ?
All right, so you're saying a high preload and a low afterload. And that
low afterload
certainly happen. For instance, I don't want to make it too complicated just right now, but like somebody who's in renal failure, who cannot excrete, so they're going to be volume excess, but they're also septic. And when they're septic and infected, they have a low afterload. They're still going to be in a lot of trouble. So it's not compensating one for the other. I don't know if I answered that question.
Yeah, I think when we get into more specific illnesses, you'll be able to correlate the picture. Like we'll talk about that a little bit more in shock. It'll definitely make more sense. But if you had somebody that had a high preload, the student was asking if they would have edema. We would expect that they would probably have edema because yes, because the fluid, you know, that ventricle is overstretched, and that means that the fluid is backing up. The pool is overfilled. So it's just like somebody that would you guys can correlate with heart failure, because, you know, think about somebody that has all of that extra fluid. It's just pouring out everywhere. It's in the interstitial edema. It's around the lung, you know. So yes, we would look for those fluid overload signs and symptoms to go along with that high preload.
Here's the thing though, we have to put all of those numbers together to get this picture. And like Joe was talking about, when I get into the different types of shock, knowing first of all what preload means and what those numbers reflect, you'll get to see that idea of how those all sort of fit together. I hope that answered. I don't know who asked the question, but I hope it answered.
They said, thank you so much. There's also another student that had a question, and they said, a low afterload is like a wide open tube. Yeah. So just confirming, because they missed it. So I thought in case somebody else missed it, if it cut out or something. So yes, that is correct. A low afterload is like the toilet paper roll or like a paper towel roll. It's wide open. And a high afterload is like a tight tube. So like a coffee stir or a very tiny straw. Okay, that's all I have right now, Dr. Comer.
All right, so we're going to share the screen again because I have a video. Now, I may have to talk. Can you see the video? Yes, no?
Yeah, well, it looks like a fluid bolus picture and then a passive leg raise. Okay.
So this is just, and I'm sorry that I don't know why I don't have sound, but I don't have sound. So we're just going to have to go with the flow. But it's trying to show you why we do this test. So let me play this video. It's not that long. This is the NICOM machine. You can see heart rate here, stroke volume here. Here's your cardiac output. Woohoo, I like that. How does it work? So these patches, instead of having a line in, it picks up. So it's just saying it's having this connection. It's picking up, and then it's transmitting all that activity that's going on within the heart back to the monitor. Don't worry about the phase shift. I just wanted to see the PLR. So we give a fluid bolus with this passive leg raise test, and we see if there's a change. And see, there's that 10%, and you say, yep, they're ready, they need more fluid. Because there's no reason to give fluid to a patient who does not need it. And again, I'd really recommend watching this with some sound if you have it. So there's no change, not fluid responsive. There you go. You don't know, check. All right, so take a look at that video when you have the opportunity.
There was a question that how long is the passive leg raise performed over to see the percentage change?
Oh, it's not long. So minutes?
I was gonna say, I always thought it was like pretty much over 2 minutes. That's what sticks out of my mind about a 2-minute test.
Yep, not long, no.
So there's another question also that says, so after the baseline numbers, do we give fluids?
Say it again, after the baseline numbers, what?
After the baseline numbers, do we give fluids?
The fluid goes with that PLR, so they're giving a fluid challenge at that time, hence why it's called challenge. So we're going to give them fluid and raise their legs and see if there's a change. If there's a change, then they are responsive and they'll probably need more fluid. We're just looking to do a little test to say they're responsive to fluid. It's not saying how much fluid they should get. It's just saying, do we see a percentage change in that stroke volume index? And do we need to give more fluid? Did that answer it?
Yes, it did. Dr. Comer, I have to help another professor with something real quick. I'm going to pop off and I'll pop right
Okay,
back
thank
on.
you for helping me.
Yeah, I'll be right back.
Okay, you guys, you got to give me a heads up if you see this or not.
I have a question.
You got to talk louder because for some reason I can't hear. Go ahead.
Can you hear me?
Yep, go ahead.
So if the fluid is given, that's just for someone who's dehydrated?
Not
that make sense?
necessarily. Remember, you could have fluid volume loss for many, many reasons. What if I was shot in the
Right.
parking lot?
Okay,
What if
right.
I mean, if we don't know if the patient is volume depleted, they come in through ER, somebody brings them, they're unresponsive. We don't really know what happened to them prior to. It could be something as simple, well, it's not simple. Dehydration is never simple. Please understand that. That's not a simple task. I didn't mean to make it sound like that, because dehydration, you can actually cause lots of problems. So it's really telling us whether the preload is low and we need volume. It's not really diagnosing why the volume is low.
Right.
Does that help?
I should have made it more specific. I meant with the low volume. That's why you were giving fluid, basically.
Say it again.
I said I should have made it more specific, but you basically answered my question.
Did
should have said
I
a
hope
low
I
volume.
did. Okay.
Yes, you did.
Okay,
Thank you.
good. Sometimes I never know about myself. Okay. All right. So now we want to talk about that equipment that we need. Now, the one that we just talked about, the NICOM, all it is those 4 patches. That's all you need. You need the machine and the patches. That's all you need. You don't need any fancy lines. You don't need anything crazy. So that's why it's nice. We don't have to, get a permit. It's not invasive. We don't worry about dropping along, all those fun things. So with the NICOM, very easy, very quick to get set up, very quickly, just to tell us preload. NICOM is just going to tell us about volume. Okay. Now we're going to get into some other types of hemodynamic monitoring. So if you remember this morning, you had some IVs set up and you had a pressure bag set up. So we're going to talk about those different things. One is you need an invasive catheter. Now our patient had a triple lumen in the subclavian and they had an art line in the brachial. I don't know if upstairs was in the brachial as well, brachial or radial. So that's going to be our invasive catheter. High pressure bag and tubing. This is special tubing. I said you needed to touch it to feel it. It's very, very hard because it has to withstand the pressure that's in that vessel. Okay, so it's very rigid, high pressurized tubing. The transducer was the thing that was set in the claw. If I don't know if Deb Phillips used the phrase claw. The transducer, and I'm digging through my stuff right now so I can show you here. But the transducer is where all the magic occurs, where we level, zero, and keep things as accurate as possible. So, but it allows us to communicate to the monitor the electrical signal. Flush system, so in that pressurized bag, you're going to have a normal saline bag. We don't use heparin anymore. And then lastly, you need a monitor because the monitor is what's going to show you the waveforms when you are connecting everything up. And there's cables within that monitor that connect up to this pressurized tubing that we're going to use. So you saw this in the lab today. This is a saline bag, pressurized. Remember I said it had to be 300 millimeters of mercury. So that green line, it has to have pressure. This solution is changed every 24 hours. So we'll pull that one down, put a new one. The tubing, this tubing here, is good for 96 hours, which is great because I don't want to disconnect from an art line. It's messy and all that fun stuff. So we can have 4 days for the tubing. You have to be inflated to 300 millimeters of mercury. You will lose your waveforms if you don't have enough pressure exerted against to have it conduct appropriately. So here's your pressurized bag tubing. This is your transducer, and I'm going to show you, I'm going to shut off the screen in a minute and show you what our transducer looks like. And then off of the transducer is this wonderful little plug that we plug to the monitor to get that waveform up there. So you see that. So pressurized bag, we have tubing. This is the transducer. This is your art line. This is the cable that allows for the transmission of the waveform up to the pressure monitor. So transducer, let me show you that first. And I'm going to shut off. All right, so I'm going to hold this up as close as I can. This right here is the transducer. This little blue pigtail, if you can see it, we call that, I call it the pigtail, but that's how you fast flush. So I can pull that and flush the line to make sure that the line's patent. This right here, we take this off and we put on, and I don't have any here, but we put on a blue cap. We put on a blue cap and we level to this port right here. We level to that port. I don't know if you guys can see that. We level to that port. Okay, and what I mean by leveling, if I can find it, is we actually use a carpenter's level. Now, if you're in a fancy hospital, they have laser levels. We do not have laser levels at Mercy. We use, and ours are about 4 feet long. They're very long. But if you look really closely, and I don't know if you can see that bubble, you have to have that bubble into the center to be leveled. So what you do is you level, and I'm going to put it this way so you guys can see. You level to that blue cap. It's not blue in here. And the other end of this level over here goes to the phlebostatic access. So let me go over this one more time. This is the pressurized tubing that connects to the pressure bag. This is a pressure bag. We would inflate it up to 300. It's going to connect to this pressurized tubing. This is the transducer. This is the end that plugs into the cable into the monitor. If we are not plugged into this, we do not get a waveform. Okay. So we're going to have a cable that comes off the monitor that will plug into this. We're going to level to this port right here. We're going to level and put the carpenter's level to here. And on the other end of the carpenter's level on this side is going to be the phlebostatic access. Okay. Now, when I said claw earlier, that's this. And if you look, we label by colors. Arterial over here is right atrial pressure, and then the yellow is pulmonary artery pressure. We will put the transducer, let me see if I can do this backwards. Ooh, you still there? Sorry. We will put the transducer into, I don't think I could do it backwards, so here, I'll just, and it sits in there. Do you see that? It sits in there. Okay, and that's, we measure up to this port here and to the other side to the phlebostatic access to make sure that we're level. Okay, if it is not level, it is not accurate. So every position change, we have to re-level, recalibrate. So we'll talk about that in a minute. Calibration is, you know how you get on a scale every day and you tap the scale and the scale goes to all zeros. You want to get on the scale when it's 0, not when there's 5+ pounds on there, whatever. We take the cap off and we put the stopcock up in the ceiling like that, and we're open. So this port right here, which I'd never put my finger on, this port right here is open to atmospheric pressure. You know what I'm talking about. So atmospheric pressure, and it's zeroing, and recalibrating this so that it's accurate. So once I have this open to air, I go over to the monitor and I hit a button. I go like this, boop, and that button says 0, and I 0, and all my numbers go down to 0 on the screen. I know that it's okay to use. Then I put the stopcock back here, and I put the cap back on here, which I lost on my desk. Okay, so that is the transducer. This is the transducer. Okay, all right. Let's go back to sharing my screen here. So, like I said, we take a carpenter's level, and the purpose is to line up the transducer with the right atrium where the catheter tip sits. So remember that CVC catheter that ends up in the superior vena cava. We want to be right level with the right atrium. So the way that we do that is we find our sternal notch, go down to the second intercostal, third intercostal, fourth intercostal, mid-axillary line. So that's the phlebostatic access. Okay, so let me show you the next slide. There it is. So come over, mid-axillary, split the axilla in half, and we put that leveler, boom, right at that bullseye. And at the end that's touching the patient, then we have the other end that's touching the transducer, and those should be level with the right atria. So leveling the transducer to the phlebostatic access, this is called the phlebostatic access right here, fourth intercostal mid-axillary line. That is leveling the transducer. That's one of two things that you need to do. You need to level, and then the next is you need to calibrate or zero. It's that scale that you get on, and you want it to go to zeros. So if it will not zero, it is not accurate. If it will not zero, it is not accurate. So that transducer that I showed you, we take off the cap right here, put the stopcock up, and we open it to atmospheric pressure. We open it up to atmospheric pressure, and we hit a button on the monitor that says 0. You hit it, all your numbers should go to 0 because we're taking it back down to 0 and clearing it out. And then we put the cap back on, and our waveform should come back. Okay, so anytime, let me repeat this, anytime you move your patient, change positions, they were in 45 and now they're in 60, or they turn to the right or turn to the left, you have to level and zero. Otherwise, your numbers are not accurate. You can have false numbers because the transducer is not level and you did not zero. So it's most important that you zero and level with every single position changed. All right, let's see where we're at here. Arterial monitoring. So we've got our tubing all set up. We've got the pressurized bag, we got the pressurized tubing. Now we're ready for the surgeon, resident, whoever, to put the art line in. Okay, so if we're putting an arterial line in, couple things first. You got to check circulation, which will be the next slide. I'll tell you about it. You don't access maybe an arm that has any lymphedema or any previous mastectomy side or any kind of circulation problems. You will not access that side. Why we put these in? Definitely if somebody comes in hypotensive, and they could be hypotensive for many reasons, but we want to see minute-to-minute blood pressure readings. All I have to do is look up at the monitor and I can see what their blood pressure is doing. It gives us a continuous systolic, diastolic, and a mean arterial pressure. And what I want to tell you, of those three, the most important is the mean arterial pressure. Circle that, star that, highlight that, whatever. Physicians, my pressure normally is 90/60. So you're like, oh my God, that's low, but I have a mean arterial pressure of 70. I'm perfectly fine. So it's important that you look at the mean arterial pressure. And a lot of those medications that we talked about that affect the blood pressure are ordered based on the mean arterial pressure. Okay. So it's minute to minute changes. We can see it, accuracy. One of the things I want you to put on the side here is you must always confirm that the art line is accurate by taking a cuff pressure, normal pressure like you normally do, in the opposite arm. They'll take it in the arm with the art line. So you want to confirm that that's really a good art line or not. So make sure that, you know, the beginning of your shift, at least once a shift, that you confirm by taking a cuff pressure that that art line is accurate. Because some of those art lines can be totally inaccurate. So it's really important that you confirm by getting a blood pressure, opposite arm, to say that those numbers match up. More precise titration of medications. Certain medications we can't run without that art line because they affect the blood pressure so much. So it's important that you know that. One of them being nipride, was one of the drugs we had you look up, or nitroprusside. And it's also helpful in management of patients who require frequent ABGs. If we have to keep sticking them in the artery, the potential to harm the patient increases the more that we poke them in the artery. So if we had a line in that we can draw from, then we don't have to poke them every time for blood gases. And when I tell you I get frequent blood gases, I've gotten them as much as every half hour, depending on how acutely ill that patient is. Sometimes it's once a day, sometimes it's twice a day. It just depends on what the physician and what's going on with the patient. All right, so the first thing we're going to do is I'm going to stop sharing and I'm going to show you how to do this, is you have to do an Allen's test prior to. So if a resident's coming in and gonna cannulate that artery, you need to make sure they do the Allen's test. So I'm going to stop sharing here, turn my little screen back on. So I want you all to take your wrist and I want you to, I kind of did this kind of backwards, but I've occluded both sides. Can you see that I have both sides occluded? And I have my hand kind of tight like this. So I have both sides occluded. If I'm going to stick the radial, which is where they're going to put the art line, not in the ulnar, I need to make sure that I have ulnar blood flow. So if you can see, my hand is really white. You see it pink up? Because we let go, you hold the radial artery. So you compress both arteries, squeeze that hand, compress both arteries. Let go of the ulnar side, make sure that hand pinks up. Because then I have collateral circulation to that hand that if I mess up this artery here, I'm still going to get blood flow to the hand. Does that make sense to everybody? Do it on yourself. It's kind of crazy. All right, so you absolutely have to do it. And even if you're going to draw blood gases like on a intermediate or another unit, you should make sure that you do an Allen's test prior to cannulating that artery. Now, if you look below, boy, that certainly looks like an IV. It's not. It's an art line. It'll say art line on the packaging. It does look a lot like, now the femoral arterial lines are longer, of course. This is one for radial or brachial, and you can see it's right here. Now, a couple things I want to tell you. Students will always say, yeah, I didn't feel the pulse there. You are not going to hurt the patient by trying to palpate the pulse there. But certainly don't hold your fingers over there for 20 minutes and really occlude it. But you certainly need to check circulation of this hand. If this becomes occluded and I lose circulation here, you're going to see this hand become cold. They're going to complain of pain in that hand. They're going to have capillary refill that's very sluggish. Your job is to make sure that you're looking at the 6 Ps to that extremity that has the arterial line in. Okay, I've had to actually put patients go to surgery to remove a clot. So we don't want to mess around with that. Think 6 Ps for this. All right, nursing management of arterial line, prevent infection. So if you look back, I'm going to flip back. This is a sterile dressing. Do not just grab a 2x2 out of your pocket and slap it over the art line. This is a sterile, just like you learned in 232 how to change CVC dressings, same concept, sterile dressing. Assessing arterial perfusion pressure. This right here, most important. You're going to learn about this in the cardiac patient. You're going to learn about that in the renal patient. A normal mean arterial pressure is 70 to 90. I'm just going to tell you, some physicians will say, I'll be happy if the MAP is 65. So I usually ask if somebody's ordering a medication to bring the blood pressure up, where they're comfortable with a mean arterial pressure. Nationally, when you take NCLEX, 70 to 90 is the normal mean arterial pressure. And what's important is that tells us how well we perfuse organs. So if I have a consistently low mean arterial pressure, if I have a consistently low mean arterial pressure, I'm not going to perfuse my liver, I'm not going to perfuse my kidneys. So you can see why it's essential, because then you're going to see multi-organ system failure because I don't have that normal mean arterial pressure. Okay, this is just a key thing. You don't ever give anything through the art line. You're never giving anything. No pushes, no IV meds, nothing. Just the pressurized tubing to keep it open. You are never to infuse anything through an arterial line. Okay. Now, I put this formula here because I used to have this pulmonologist who said, doesn't your students know how to calculate a mean arterial pressure? And I said, yes, of course they do. Certainly I look at the machine and it tells me. But if you let's say we have a pressure of 120 over 80. Let's say we have a pressure of 120 over 80. So if you look at this formula, diastole times 2, so that's 80 times 2, right? Because I said 120 over 80. So 80 times 2, right? Plus that 120. So we have 160, right? Plus 120 divided by 3. So 160 plus 120. Hang on, I'm trying to find my calculator. 280 divided by 3, right? Everybody got that? So what'd you get? 280 divided by 3. Anybody? Nobody has a mean arterial pressure. Oh, wait, you're typing it in.
93.3.
Yeah, you got it, 93.3. Now your brain might say, hey, that's a little high. Okay, don't lose sleep over that. It is. And didn't we all think that 120 over 80 was supposed to be a normal pressure? So you can see it's a little bit slightly above normal. We won't lose sleep over it. Here's the beauty of all this, you guys. If they have an art line on, and I'll show you in a minute, the monitor tells you your mean arterial pressure. You don't even have to calculate it. I told you I'm lazy, so I like everything right at my fingertips. So the monitor will actually give us a mean arterial pressure. All I want to say about this particular slide, honest to God, please do not study number 1, number 2, number 3, number 4. The only one that's really important is this number 2. And what number 2 reflects is the closure of the aortic valve. And this is right before diastole occurs. It's called the dicrotic notch because you're looking for that in the waveform. You're seeing this little doop. So this is systole up here. This is right before diastole, and then this is diastole down here, okay? So the dicrotic notch is the closure of the aortic valve right before diastole. So top number is going to be systole, so around like, you see 150 there? And then down here, probably 60 something, okay? So don't measure or don't memorize 1, 2, 3, 4. Just understand the dicrotic notch is where the aortic valve closes right before diastole. If you don't have this type of waveform for your art line, something is wrong. So we've got to troubleshoot because it should look like this. This is a very characteristic art line waveform. Now, the higher the blood pressure, the higher the peak of that number 1 is going to be. So you're going to have bigger waveform. The lower the blood pressure, you're going to have a smaller waveform. That totally makes sense. Okay, so depending on what that blood pressure is.
Lorraine.
Mm-hmm.
So like if you have like an irregular heartbeat, does that mess with it?
No, what'll happen is if you look at the monitor, and I think I have a picture later, with every contraction, you should see an arterial waveform. They should match up. So you have your QRS waveform, and right below it should be this waveform right here. If I'm irregular, you're just going to see those irregular. It's going to come early. So it's not going to look regular, just like in your irregular heartbeat. Here's the problem with irregular heartbeats, or rhythms, sorry, irregular heart rhythms is if it comes too soon, that heart doesn't have an opportunity to fill appropriately, so your cardiac output drops. That's why people like an atrial fibrillation with rapid ventricular response, you worry about them because that heart doesn't have an opportunity to get that cardiac output out. It's too fast. It's coming too fast. We don't have that appropriate stroke volume. So, and same thing with irregularity. If that beat comes early, it doesn't have the opportunity to have this beautiful waveform. Does that answer the question?
Yes, it did. Thank you.
Okay. All right. So if we think there's something wrong with our waveform, we will troubleshoot. So if you remember, I said that little blue pigtail, and when you go back to watch this video again, you'll see it even closer. But what we do is do something called a square wave test. And I'm looking at the monitor, and I want you to look here. This is the waveform. Do you see it right there? Beautiful waveform. And I do this square waveform test. And what that means is, as I'm looking at the monitor, I pull that pigtail and I'm flushing the line. Everybody got that? So we lose our waveform. And it turns it out, until I let go of that blue pigtail, it's going to be flat like that. Okay? And once I let go, it has these oscillations afterwards. This is a normal, this is what's expected, square wave test. It tells me, hey, that's a pretty accurate waveform. We should have a couple oscillations. Do you see them right here? Doot, 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 doot. Couple oscillations and then right back to our waveform. When we are underdamped, which is this next one, we got all, look at this chaos here. Da, 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 lots of oscillations here. When we are underdamped, it can overestimate the systolic blood pressure. It can overestimate the systolic blood pressure. So we don't want an underdampened waveform. Okay. And then when we're over dampened, this one on the end, you see how it looks kind of and it doesn't really have that beautiful notch here. It's kind of flat and kind of bleh. And there's not really oscillations after this. There could be, for over damped, there could be an error in the line, because you should never have air in the line. It could be disconnected. It can have a low pressure. So remember that 300 millimeters of mercury? We're not getting, and it's an inaccurate measurement of the blood pressure. It's not really reflecting what it is. So as you can see, you want a couple oscillations. This is a normal, I pull the pigtail, I lose my waveform, and it sharp snaps back, gives me these oscillations here. That's expected. And then my waveform comes back. When I've got this chaos here, that's called underdampen, and it can overestimate the systolic blood pressure. So it's not going to give us accurate readings. And this right here, when I think of overdamped, I think of like a flat. Is there a bubble in the line? Is there a kink in the line? Is the patient's wrist bent? Is there a disconnection? Is there not enough pressure in the tubing? Everybody get that?
Can you say that again, Lorraine?
Yep. The overdamped?
Yeah, just the overdamped.
Okay.
Lorraine, when
so
you're moving your mouse, we can't see it.
you can't see me moving the mouse?
No.
Huh.
It's
Okay,
different
sorry,
than it
Bob.
normally looks. It's like we can see the time recording. We can see the next slide. It's not like we can just see the one slide anymore.
Oh, you're kidding. Let me stop share and try sharing again. Stop share. Can you see the one slide?
No, it's the same still.
Is it advancing?
Yeah, it advances, but we can it makes it smaller and then we can't see your cursor at all.
That's so weird.
And it's like it'll say next slide to the right and we see that, and then we see like slide 26 of 67. We see how long it's been recording.
Let me see if that. That's so weird. All right, what do you see now?
Now it's back.
Can you see my cursor?
Yep.
Oh, goody. Okay, good.
Thank
Keep me
you.
posted. I have a new laptop, so things are just, I don't even want to talk about it. All right, so let's go over this again then, since you couldn't see my cursor. It's anticipated to have this beautiful square waveform with a few oscillations. Do you see that? That's expected. So I pull that little blue pigtail. I stop the waveform because I'm flushing the line very fast, and then I let go, and it oscillates. Boom, 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 boom. That's expected. Underdamped, too many oscillations. You see that craziness right here? Too many oscillations. It's overestimating the patient's systolic blood pressure. Overestimating the patient's systolic blood pressure. And then the last, the overdamped, is it's definitely either a kinked line or an error in the line, or a disconnect, or not enough pressure within the bag. Not enough pressure within the bag. So I've got a problem solved now because I have absolutely no oscillations over here. Okay, so now I got a problem shoot, like, is the patient's wrist kinked? Is there an air bubble stuck in that line because somebody drew blood from there and got air in the line or something? So I've got to troubleshoot, because ideally we want to be here. We want that beautiful square and then a few oscillations, not this chaos in the middle. And if we have none at all, it's overdamped. Really take a look. And I probably would say I see overdamped more often than underdamped. And it's usually due to the position of the patient. They have their arm bent, or that the line's just not in the correct place.
Dr.
Okay.
Comer, so
Yes.
with all three of those, we're focusing on after the square wave. Like after
Correct.
that flat line. That
Correct.
blue that's circled, we don't really have to focus on right now.
The what circle? Say it again.
The blue section where the peaks are, we don't have to focus on that. for
Well, you
this.
should, because that's your actual waveform that you'll see on the monitor before you start doing the square waveform. It should go
Okay.
back to where you started.
Okay, so you could compare. Okay.
Yes, yes,
All right,
yes, yes,
thank
yes,
you.
yes, yes. Okay, new nurse is orienting to manage hemodynamic pressure lines. Which sequence of actions demonstrates that the new nurse understood the instructions? So I want you to take a look at those answers. I'm going to take a sip of coffee while you're reading them, and you tell me what you think the answer is.
Lorraine, I have a quick question.
Okay, talk a little louder.
So when are we doing the blue pigtail thing?
After you do this, well, I don't want to give you the answers on, but you do that after you have done these procedures.
Okay, and we're just checking to see if it's accurate. That's why we're
Correct.
doing it?
So what shows accuracy in my lines? What are the two things I need to do?
You have to level it and then zero it out.
Right. So after I've leveled and zeroed, then I'm gonna square wave test it really quickly.
Okay, that makes sense.
It's all kind of together to start your day off to say this is an accurate measurement of what that blood pressure should be.
Okay,
That
thank you.
help?
Yes, thank you.
Good. Okay, so what do you guys think the answer is here? Nobody?
A.
Yeah, it's A. We got to find the phlebostatic axis. We're going to level it. Then we're going to zero it. Then we're going to take a reading. Okay.
Dr. Comer, I have a question.
Sure.
So like the last one, how you said the overdamped, how you have to troubleshoot it and kind of figure out what's causing that. Is there a way to troubleshoot the underdamped or no?
You really should. Yes. To answer your question, yes. Honestly, I can't think of a time that I've seen the underdamped. It's more often than not that I have an empty bag, I have air in my line, or the patient's kink that I see the overdamped. I'm not gonna lie. It's more often I've seen the overdamped than the underdamped. But you need to troubleshoot both because it shouldn't be either.
Thank
That
you.
help?
Yep, thank you.
Oh, okay, good. All right. Which priority actions should be performed before inserting an art line?
A.
Absolutely. Now you might say to me, well, Lorraine, I want to know the platelet. And you're definitely going to do that, but you're not, I mean, these are all right. Set up the double transducer, do that, get the saline. It would be 500 of saline. You would do all that, but the priority is to see if they have adequate blood flow. No one's sticking them in the artery if they don't have adequate blood flow. Okay, so don't bother setting stuff up. Don't bother looking at the platelets. You're not going to even stick them if they don't have adequate blood flow. Good. Oop. All right. Everybody good? Everybody still with me?
I have a question.
Yeah.
This was for, I think, the first one that we did. That
A little bit louder. I'm sorry, I can't hear you. Go ahead.
I said this is for the first one that we did that I have a question on. I had chose D. So why, like, does, well, it does obviously, but why couldn't you zero it before?
Zero. You want to be at the right spot. You want to level before you zero the transducer. This comes after. Remember, we're locating the phlebostatic access to level. Those two go together. Phlebostatic access, level the transducer.
Okay.
Then you zero. Then you take your reading. Does that help?
Yep.
All right. Everybody still with me?
All good.
You're good? Okay. All right. Let's keep going. Pulmonary artery pressure monitoring. Now remember, this is the most invasive. And this one throws students off. So we're going to take some time on this. I don't even know what time it is. Okay, it's 1:19. We're doing okay. And we might get done early today. We'll see. We'll plug along and we'll see where we're at. So most invasive, it gives us direct and indirect measurements. Here's what's important. The catheter is only in the right side of the heart, and it ends up in the pulmonary artery. Back to that antique picture that I told you guys to print, it makes sense because we cannot go through the right atria, down to the right ventricle, into the pulmonary artery, through all the pulmonary vasculature and lungs, and then come back to the left side. So we get indirect measurements of the left side of the heart. We don't have direct measurements like the right. We're going to get cardiac output. We're not going to do mixed venous. I haven't seen that much anymore. In the pulmonary artery, we've got some deoxygenated blood. Remember, the pulmonary artery is the only artery in the body that has deoxygenated blood. So we're looking at venous blood. And then optimal infusion of fluids and vasoactive medications. And some of the medications that we had you look up, we'll talk about. Okay, so you're going to hear people abbreviate this to as SWAN, but it's a pulmonary artery catheter. It's just like tissues for your nose. There's either Puffs or Kleenex. Those are the brand names. Same concept here. So this is a pulmonary artery catheter, also known as Swan-Ganz. Oh God, she spelled that wrong. S-W-A-N. Move the A and the W. That's backwards. Should be swan, like the bird. Now, what I want to say about this, because you're all going to flip out when I go to the next slide, do not memorize what port is what. I'm going to tell you so you understand if you see a swan, what they're doing. But I am not going to say, please tell me what you can do through proximal injectate or proximal infusion. Okay. So when you look at the Swan-Ganz catheter, and I'll hold mine up in a minute when we get to future slides, there's, as you can see, 5 different ports right here. All right. And then there's also a Swan that you can do pacemaking through. You could do a pacemaker through the Swan as well. So depending on what type of Swan's put in. And each port is really kind of important. So we'll kind of talk about it because you're probably going to see the nurses doing things with that. So just kind of getting an idea of what, but I'm not, see this slide right here? And it even says don't memorize. Okay. But your proximal infusion, and it ends up in the right atrium, and we use it as a central line. So just like if we had a triple lumen catheter, we would use it as a central line. So we can run fluids through here. We don't normally run blood through Swan. I don't know if CVIC is doing something different, but we usually put in another line to run blood. I don't normally run blood through a Swan. But the proximal infusion lumen, treat it like a central line, you know, vasoactive medications, those kind of things. Excuse me. It ends up in the pulmonary artery, and it gives us a pulmonary artery pressure reading. So that's at PAP, pulmonary artery pressure reading. And when we inflate the balloon at the end, we can get something called the pulmonary artery occlusion pressure, or wedge, pulmonary artery occlusion pressure, or wedge. We don't ever put medications through that, okay? And then the thermistor is where we connect to another cable that goes to the monitor, and it gives us a continuous core body temperature. It gives us a continuous core body, because we need to know the patient's body temperature to evaluate cardiac output, and I'll show you that in a minute. The balloon inflation lumen, that is only the port that we connect a special syringe that can only open up to 1.5 milliliters. Don't ever attach another syringe to this. It comes with a special syringe. I'll show you it in a minute. And it inflates the balloon. It inflates the balloon so we can float the catheter forward and wedge the catheter. So it inflates the balloon so we can float the catheter forward to get a wedge pressure. Don't panic if you don't know what a wedge pressure is yet. I'm going to tell you. And then the proximal injectate lumen, that ends in the right atrium. So that gives us that beautiful right atrial pressure, or CVP. And this is where we inject solution to measure the cardiac output. And I have a video to show you. So you're like, I don't know what the hell she's talking about. I'm going to show you a video. All right, complications of the Swan, big thing. And I think only once in my career did one go up into the neck and up into a vessel up into the neck. And you cannot use these without the x-ray. I have had it infarct and rupture pulmonary artery, and patient just bled. Air embolism is always an issue with central lines, so you want to make sure of that. Infection, of course. And the dysrhythmias, because when we insert this bangs around in the heart on insertion, it can certainly cause problems in the patient's heart. So I'm going to show you my Swan. So this is the Swan. Let me see right there. And then you can see all these ports. So this port right here, that port connects to a cable to the monitor to get a continuous temperature reading. That port connects to a cable to the monitor to get me a core body temperature. This is the balloon port right there. And that's, I can't pull the syringe back any further. It can only go back 1.5 mLs. The balloon will rupture if you put in any more than that. Okay. So it's the balloon port valve. And you can see the line, it's actually shut off. So I'm going to open it. Do you see how it's straight now? Now I can inject the air and inflate the balloon. Okay, and then we let go and we let it passively come back. Okay, so that's the balloon. We only use this to get a wedge pressure. We only inflate the balloon to get a wedge pressure. All right, and then this port, that's the pulmonary artery pressure. And here's the beauty of this one. It says it right there. It says PA distal. Okay, that's the port that we connect pressurized tubing to get a pulmonary artery pressure reading. Okay, and then last, we talked about that CVP, or right atrial pressure. See the blue? And remember the blue stickers on the claw today? This is where we would get the right atrial pressure, and it's also the port where we inject for cardiac outputs. Okay, and I want you to see how long this catheter is. You see that? And if you have the opportunity when you're, I don't know, back at school or whatever, we'll set one of these out. But you have to know where it's marked, because it could slide forward or it could slide back, and it won't be in the right place, and then we have problems. Okay. All right. I used to love when we were putting these in. I told you I'm a nerd like that. I like those kind of, I like to see those numbers. I like to see, the treatments that we're doing are effective. So for me, I really enjoyed taking care of patients with the Swan. So what I do is really just stand there and look pretty while the physician does all the work, and I watch the monitor. So my job as a nurse is to watch the monitor. So when we first insert it, and it's going to be inserted either through the IJ or the subclavian. I have seen Swans inserted in the femoral, which is gross, but so most often than not, it's going to be in the subclavian or the internal jugular. And I say, hey, doc, I see a right atrial waveform. So he knows once this waveform shows up, he'll inflate the balloon, because inflating the balloon on insertion helps the catheter float forward. Okay, so I say, oh, I see a right atrial pressure. And then as we get through that valve, that tricuspid valve, we're in the right ventricle. Do you see how sharp and dramatic these waveforms are? Only time that you should see right ventricular waveform is on insertion. Let me say that one more time. The only time that you should ever see a right ventricular waveform is on insertion of a catheter. It's got to get through the right ventricle, and then it's got to tip up and go into the pulmonary artery. And I want you to look at this pulmonary artery pressure waveform. Looks a lot like the arterial waveform. However, it is not, let me repeat this, it is not a blood pressure. It is a pulmonary pressure. It is not a blood pressure. You will not get arterial blood gases from this line. It's deoxygenated blood. So it is just measuring the pressure within the pulmonary artery. And then I say to the doc, okay, we're in the pulmonary artery. I see the waveform. And then he keeps the balloon inflated, and then it goes forward even more and wedges. Now, interesting enough, doesn't this look like this waveform? So right atrial pressure and pulmonary artery occlusive pressure are the two measurements for preload. Now, the pulmonary artery occlusive pressure, or wedge, is a little bit higher. It's 4 to 12, where the right atrial pressure is 2 to 5. Don't panic, those numbers are coming up. So during this insertion, we're very worried about going through the right ventricle and causing ventricular arrhythmias or dysrhythmias, whatever you want, whatever word you prefer to use. Because that catheter is banging around that very excitable ventricle, it can cause VTAC, VFib. So I always tell the physician, I saw a PVC, I saw a run of VTAC. Uh-oh, pull back, he's in VFib, whatever. So your job during the insertion is to really monitor those waveforms to make sure that they're not having any kind of ventricular dysrhythmias. Cannot use until you have a stat chest x-ray, because remember I said one went up into the neck. And then we're going to get some hemodynamic readings once we've confirmed placement. Okay, once we've confirmed placement. All right, so let me see. There's no sound of this one, but this is getting a cardiac output. So remember I said that proximal injectate port, this is giving a CVP, but I inject 10 milliliters of saline, and it goes past the temperature probe, and it gives me this waveform. And we'll watch this a couple times. And it says, wait a minute, your cardiac output is this. Okay. So what happens? Let me go over this again. We'll go back to the beginning. Catheter's already in. Now we're getting a cardiac output. Well, let me play this video first. Maybe that might be helpful. Stop share. Hang on 1 second. Screen share. Can you guys see my YouTube video? Somebody just tell me yes.
Yes.
Okay, so there's no sound to it, I'm sorry, but this is placement. So I'm in the right atrium. He's going to inflate the balloon. My job is to watch the monitor. I say, hey, doc, I see a right atrial waveform. He's going to keep advancing. Now watch how sharply, look at that. I know I'm in the right ventricle, doc. He's going to keep going. So he goes to the pulmonic valve, and I see a change in my waveform. And now I know I'm wedged in a small branch of the pulmonary artery. Then I let the balloon deflate, and I always have a continuous reading of a pulmonary, and oh, we inflated again. And the pulmonary artery pressure comes back. Okay, so let's play that again. I think it does a nice job.
That helped very much.
Mm-hmm. Okay, so here I am. I'm at the bedside looking all pretty. I'm waiting for the physician. He's inserting, and I look at the monitor, and oh my goodness, doc, I see a right atrial waveform. And that's our job as nurses, to recognize these waveforms. And he goes, okay, I'm going to continue to advance the catheter. And I say, doc, now you're in the ventricle. Big, big waveforms. Watch for PVCs, watch for complications there. Oh, we had a change in that pulmonary artery pressure. And now I know I'm wedged. Let's let the balloon go. Back to pulmonary artery pressure. He's going to check it again before we x-ray, and he's going to wedge it again. And back to pulmonary artery. Anytime you walk into the room with somebody with a swan, you should always, always, always see a pulmonary artery pressure reading. That's a continuous reading. All right, so the top video, that YouTube video, is insertion of the catheter. Now we have to get cardiac outputs. So the catheter is already in place, but the doctor wants to know what the patient's cardiac output is. So we're going to play this. The catheter is already placed. So I'm not doing anything except for injecting 10 mLs. 10 mLs. And because the IV solution is colder than the body temperature, IV solution is not the patient's body temperature. That temperature probe senses the change and does a measurement. And that's how we get the cardiac output. Let me do that again. Because I'm injecting IV solution that is not body temperature. See, I'm injecting 10 mLs, and it's going in, and it's going past the thermistor right here. It's going past the temperature probe, and it's saying hello, and it measures the cardiac output. I hit a button on the monitor, and that's all I do. And it gives us that number. Okay? So that's getting a cardiac output.
So is that solution in the right atrium?
Yes. So that's, remember I called that port the proximal injectate. So that's where we inject. And what it needs to do is then go past that thermistor, which is further down in the pulmonary artery.
The artery.
So it measures the amount, that 10 mLs, and you've got to do it quickly. You've got to do it over about 4 seconds. If you go too slow, you have a really crappy cardiac output. The other thing is we do the best of 3. So we do an average of the 3. So let's say I get a cardiac output of 4, and I get a 4.1, and then I get a 7. I'm going to toss the 7. Do you guys see that? And I'm going to average the 4 and the 4.1. So we do 3. We shoot 3 cardiac outputs, and we take an average. And if one's an outlier, we toss it. Because I did something wrong on injecting or something along those lines. Okay, so this is just another visual of what it looks like on insertion. So it matches up. Do you see here? I'm in the right atria. Nice little CVP pressure or right atrial pressure. Uh-oh, ventricle, big, dramatic. And then once I go up into the pulmonary artery, it almost looks like a blood pressure, like an arterial line. And then when it's wedged, it's small. Okay. Never, ever, ever leave the balloon inflated. You will infarct the lung. You will infarct the lung. So never, ever, ever, ever leave the balloon inflated. You let that balloon come back. If you see this waveform and you haven't touched the catheter or something's wrong, if you see this waveform as you walk into the room, the only waveforms you should see continuous, and they're written down there, right here. So if I see this or this, I've got to troubleshoot. That's an emergency. Okay, this one's more of an emergency than this one. No, actually, they both are. So on the monitor, if I have a swan in, these are the only two, the right atrial and the pulmonary artery pressures, should I see continuously. These guys, I have to do something for it. This is on insertion. This is when I inflate the balloon. The balloon should never be permanently inflated. You need to have that balloon come down. It needs to just free float in the pulmonary artery. All right, so sterile dressing change again. You need to know what normal waveforms look like. I had to take a class when I started working in the ICU on how to monitor these waveforms. So if you're deciding to do a critical care area, they'll send you to class. You read it end expiration because the numbers are more accurate. So you have to kind of look at your patient and see when they're exhaling. It's different when they're on a vent. You want to interpret abnormal waveforms and trends. If you get a really wacky number and it hasn't been that way for 2 days, you have to start with you, and is it you that made the mistake? Or is something disconnected or something you have to troubleshoot before you start calling out the cavalry to come and fix this. You're always looking for dysrhythmias because the potential for the catheter to slip back, is a problem. So if I see, write this down, if I see a right ventricular waveform when I walk into the room and we're not inserting, it's an emergency. We need to call the doctor and have him advance the catheter. It has slipped back into the right ventricle. If I see a right ventricular waveform on the monitor, I must call the physician and have him come and advance the catheter. It has slipped back into the right ventricle. Now, spontaneous wedging is that catheter just wedged itself in a branch of the pulmonary artery. I didn't inflate the balloon. I didn't do anything to get the wedge. And I see that wedge waveform and I haven't touched the patient. Couple things you can do. You can reposition the patient because it might like loosen it up and get it out of that wedged position. You can have them cough. You can suction them. If you can't get it to unwedge, you need to call and have a physician. But with the spontaneous wedging, there are things that you could do as a nurse first. The catheter being out too far and the dysrhythmia one here, you got to call somebody. They have to advance the catheter. Here, they may have to pull back on the catheter if you're suctioning, coughing, repositioning didn't help the patient resolve that issue. Okay. There's your spontaneous wedging. And you could take a look at that. I think I just said all that. All right. So things that we can get or parameters that we can get. We can get this right atrial pressure or central venous pressure, either one, and I'll put both of them on the test because some old school people know it as CVP, some know it as RAP. You can get this one, and it's right here, only value that can be obtained by a triple lumen or a PICC line, because the PICC line is peripherally inserted central catheter. It has to be central, no peripheral lines. But that's the only thing that you could get from a triple lumen or a PICC line. You can get this with the Swan as well, okay? Because there's a port in the Swan called the right atrial port. So yes, do you need to know these numbers? 100% yes. So a normal right atrial pressure CVP is 2 to 5. And this reflects, I have it right here in capitals, the right ventricular preload. So this number, hence why it's called right atrial pressure, reflects preload on the right side of the heart. It reflects preload on the right side of the heart. So if I have right-sided heart failure and I have a big PE, there could be a lot of pressure because I can't get that volume out. That preload and that afterload will be really high on that right side of the heart. You want to always look at the heart right versus left. Sometimes it can be occurring on both sides of the heart, but you always want to look right versus left. So as you walk into the room, and if we're measuring right atrial pressure or CVP, whatever one you want to call it, it's a continuous reading. I should walk in the room and I could look up at the monitor and I can see CVP or RAP. Okay, I don't have to do anything. I could just see what it is. Here's the thing. If the patient has changed positions, in the meantime, shouldn't I level and zero again? Always, always, always. Don't go, oh, their CVP is now 50 when they've moved in the bed and it's not accurate. So when you start seeing numbers that don't match up to what they've been running, go back to the beginning, re-level, re-zero, calibrate, do the square wave test, do all of that to ensure the accuracy of your numbers. No physician likes to be called at 4 a.m. with a stupid number that's not accurate. They'll be really, really mad at you. Okay, so normal right atrial pressure, and if this is reflective of fluid volume status, if it's high, I have fluid volume excess, so anything greater than 5, 6, 7, 8, 9, 10 up. If it's low, I have fluid volume deficit, okay? Because it's telling me volume status. It's telling me volume status. So if it's high, I have excess volume. If it's low, I have deficit volume. All right, so she did a nice job of like highlighting. When I walk into the room, this is what I should see right here on the monitor. That's a CVP or right atrial pressure at all times, continuous. Please don't memorize. This has to do with valve closures and all this crazy stuff. Don't memorize ACV. No one's going to ask you that. But if you see, here's your EKG right above, you have a waveform right after that QRS. So with every QRS, we have a waveform. So right atrial pressure, couple things. It's continuous, 2 to 5. Get that in your brain, 2 to 5. So what does an increased right atrial pressure or right CVP mean? Volume overload. And this certainly looks like a right-sided heart failure patient who has that significant peripheral pitting edema. Okay. And I have left ventricular, left heart failure, because eventually if my left side fails, it's going to back up, back up, back up, back up. The right side's going to fail as well. Okay. More often than not, I see a lot of right-sided heart failure with my COPDers because they have terribly high pulmonary artery pressures because they have damaged lungs from smoking. So you'll see an elevated CVP with COPD or pulmonary embolism because I have pressure within that pulmonary artery and it backs up to the right side of the heart. All of these, you guys know this right here. This is all fluid volume excess. And you can see the pitting edema here. S3 or S4, they're going to be tachycardic. They're going to have distended neck veins at 45 and 90. They can have liver engorgement with significant fluid volume excess. And they could have dependent or generalized edema. And generalized edema, you might read anasarca. Anasarca. Anasarca means generalized edema. Or ascites. They may have pleural effusions in their chest x-rays. Okay, so looking at those x-rays, looking at every diagnostic test that this patient has is going to help you understand what's going on with the patient. So what do? We want to reduce, right? So simple enough, we can fluid restrict and sodium restrict. If they're acutely decompensating, we may give diuretics. Now, this is a loop diuretic. There are other types out there. Just depends. And I don't know if you know this. I learned this a couple years ago, so I always share this with students. LACE-6, it lasts for 6 hours, so that's why it's 6. I don't know. I just thought that was a fun fact. No one's ever going to test you on that. So the other thing that you may need to do is give some vasodilating medications as well. So you might see nitroglycerin or Tridale, which does a beautiful job on the venous side. And it'll help decrease venous return, which would therefore help decrease that CVP as well. So you might see them on a nitroglycerin or a Tridale drip. Not that often unless they probably have an MI, which you'll learn about when you go to CVIC. You are absolutely going to weigh these patients daily. Daily, absolutely. And INO, strict INO. So you're going to make sure that you're doing intake and output every hour, output every hour. Intake, we'll do at the end of the shift, but we do hourly outputs. We don't wait. So if I give Lasix at 8 a.m., you want to be reporting to the physician by 9 or 10, hey, put out a liter, didn't put out anything, because we may have to do something else. So you're always going back and evaluating the response to what you've done, okay? And here's the beauty, and I told the groups that I was with today, I was like, I always think I'm super nurse because I start off with a CVP of 30, let's say 30. They're in full-blown CHF, pulmonary edema, and I give Lasix, a big dose of Lasix, and they pee out 4 liters. And their lungs are clearing up. They don't have the crackles anymore. And I see the CVP go from 30 down to 15. What a beautiful response. And what a very visual way to see that your interventions were effective. So that's how you're going to evaluate the effectiveness of your response, is taking a look at those numbers. You don't just go, oh, all right, so the CVP is 30 and you move on. No, you do something about it and then you reevaluate to see if what you've done has been effective. Decrease, so volume deficit. Well, seeing a lot of dehydration patients, people really, really sick at home with COVID, and then they come in and their tongues look exact. That's why you need to look in people's mouths. Those are fissures. That is significant dry mucous membranes. That's a quick way of looking to see if you think somebody's dehydrated. Okay. Now, if we vasodilate, it's not that we've lost volume. It just appears that my pool is empty because my pipes are wide open. So we haven't lost volume, but it appears that I have it. I look volume depleted because I'm massively vasodilated, okay? And then diuretics are great, but I can overshoot and I can really dry somebody out and really drop them down. That's why you need to constantly be evaluating if they need diuretics or not. And then rewarming them after surgery could be an issue. I've not seen that because I don't take care of them after surgery. They come up once they've been recovered. Very classic fluid volume deficit findings, very classic, okay? And your brain says, well, if I'm fluid volume deficit, what should I do? I should give volume. Now, students always say, well, what should I give, fluids or blood? Well, it's not for you to make that decision. It's for the physician to, or healthcare provider. You just need to be prepared to give either or. And common sense says if I'm a gunshot wound, you better be giving me blood. If I'm a severely dehydrated patient, you're probably going to give me some normal saline because I haven't lost blood. I've just lost fluid. So it really depends on the patient's condition on what you need to anticipate giving. It could be either or, it could be both. It could be drink this water, give them back oral fluid replacement. Certainly if, and really treat the cause for any of this. So put this up here, treat the cause. If I'm hemorrhaging, for God's sakes, please send me to surgery so that they fix wherever I'm hemorrhaging from, okay? If I'm severely dehydrated, I'm not going to surgery. I'm just getting fluids back because I've been vomiting and having diarrhea for, a month or whatever. I hope not a month. We're going to do some vasoconstricting medications after we have given back the volume. So if it's a volume issue, we want to start with that. Now, certainly we can give a lot of volume and they still have a really, really bad blood pressure, bad RAP. We may give some vasoconstriction meds. And we had that norepinephrine or Levophed running today. Epinephrine is another one that we give. And it helps bring that toilet paper roll back down to the straw. Maybe they've lost tone in their vessels for whatever reason. All right, all I want to say about this slide is you should not see it. notify the end, don't study the numbers. This is on insertion. You just need to know that that should never be only on insertion. And it's quite large. You'll know you're in the ventricle. You just need to be able to recognize that waveform so that if the catheter has slipped back, you're going to call the physician immediately to advance that catheter. You are not to ever advance a Swan-Ganz catheter. Let me say that one more time. Do not ever advance a Swan-Ganz catheter. You will call whoever inserted it to come in and advance it. All right, this is a continuous waveform that you'll see on the monitor. So a pulmonary artery pressure has a systolic, that's this top number, 20 to 30, over a diastolic. I will say this one more time. It is not a blood pressure. It is not a blood pressure. Do not get blood gases from this. This is not arterial blood. But it tells me the amount of pressure within that pulmonary artery. And that's important to know because we have a lot of patients with pulmonary hypertension. And we'll see these crazy numbers, like the highest I think I've seen this is like 70 over 40. High amounts of pressure within the pulmonary artery. And anybody know what med I'd give to help with pulmonary hypertension? Anybody?
Isn't that what they accidentally had that one med for? That was supposed, or no, that's the other way around, isn't it?
Say it again.
I can't remember. There was a med that was supposed to be for something and it helps with pulmonary hypertension.
No, you got it flipped. So
yeah, I have
this
it flipped.
drug
That's
is
what I was saying.
for pulmonary hypertension, but it helps with the erectile dysfunction.
Yeah, that's what it was. Sorry.
Viagra. So Viagra, when Viagra came on the scene, guys, Viagra was for pulmonary hypertension, but they had this side effect and they're like, wait a minute, let's forget about the pulmonary hypertension patients and let's market this drug for the erectile dysfunction patient. So the first time I had to give a lady Viagra in the ICU, I was like, and I didn't know it was for pulmonary hypertension. I had to look it up. So it is, we do give Viagra, Cialis, for pulmonary hypertension, okay? You're gonna see really, really high pulmonary artery pressure numbers. You're gonna see really, really high pulmonary artery pressure numbers, okay? This is something I can walk into the room, I can look up at the monitor, and I can absolutely 100% see that waveform. I don't have to do anything. It's continuously reading on the monitor. So that's a beautiful thing. So that's this one right here, okay? And it looks a lot like the arterial waveform, doesn't it? I'm just gonna tell you, it is not a blood pressure. And the only reason why I say this is because somebody drew blood gases from the Swan and called the physician in the middle of the night and their oxygen level was 70 and he was flipping out. It was deoxygenated blood, you guys. So it's really important. This is not a blood pressure. This is not a blood pressure. Okay, so we used to break it down of why pulmonary systolic was high. We just lump them together now. So why do we have high pulmonary artery pressures? And I've already told you pulmonary hypertension is a common one. Heart failure, valvular disease, particularly on that side of the heart. So that would be the tricuspid. COPD, PE, and ARDS. So Jill's going to talk to you guys about ARDS in a couple semesters, or couple of semesters. Jesus, you're graduating. A couple classes. I think Thursday she'll talk to you about ARDS. Okay, so what do they look like? They're short of breath. Cardiac output might be decreased. They might be fatigued. They're going to have crackles. They're going to have edema. They're going to have JVD, or that's NVD, neck vein distension, and chest pain. So we want to bring this pulmonary hypertension and this pressure down within that pulmonary artery. So what do? Well, could it be a preload issue? Yes. So if they have a high right atrial pressure, so we know their fluid volume excess, we might give diuretics. That'll help it go down. if I need to dilate the pulmonary artery because I have pulmonary hypertension, Velitri we can give. Here's your Viagra. I've not given calcium channel blockers, but maybe the cardiologist has done that and I just didn't know. We are going to possibly give a positive inotrope like DIG or dobutamine to help cardiac contractility. And you're going to absolutely do strict intake and output, daily weights. You can see the common theme here, right? And then planned activity and rest periods in between. Decreased. We don't have enough circulating volume. And, you know, that dehydrated patient can have a low pulmonary artery pressure. They're going to be hypotensive, tachycardia, because we're trying to increase the heart rate to get that blood flow out. There's just not enough blood flow. Thirst, decreased urine output. So that's one of the first things that we'll see in the ICU is the urine output drops when we have a volume issue that drops. So if we're really thinking volume deficit, we're going to see that lack of urinary output. And we're like, wait a minute, they used to put out 100 an hour. Now they're only putting out 10 an hour. Okay. And then poor skin turgor goes along with volume deficit. So optimizing preload by restoring volume. So again, back to that dehydrated patient or that gunshot trauma that's bleeding, we either give blood products or IV fluids, or if there's an extra P there, I see that, get rid of that. Oral fluid replacement. And again, same nursing management, intake and output, daily weight, maybe get a cardiac output, see how that patient's doing. Vital signs every single hour, okay? All right, wedge. Now we're working our way through that heart picture. We've done the right atrial pressure. We've talked about the right ventricle, which we should only see on insertion. And then we talked about the pressures within the pulmonary artery. Now we're going to get to the left side of the heart where we cannot directly measure. So it's an indirect measurement. And they're now calling it the PAOP, but when I started, it was called the PCWP, or the pulmonary capillary wedge pressure. You'll hear different people use different phrases, but it's the wedge. 5 to 12. I learned 4 to 12, but that's okay. 5 to 12. An indirect measurement of left ventricular preload. So if I want to know volume status on the left side of the heart, I'm going to get a wedge. Now, we're not wedging as often as we used to because of those complications of infarcting and really causing a problem in one of those little pulmonary artery branches. So I don't see them wedging as frequently, but understanding the concept that the wedge is the left side preload. So break that heart up, left side preload. So as we do the wedge, the catheter balloon is inflated slowly, allowing the catheter to float forward into a small branch of the pulmonary artery. So we're floating forward, and it stops the forward flow of blood. So catheter can see the pressure in the left because it's all an open chamber, and it's not in the left side of the heart, guys. It indirect measures the left side of what's going on. Okay, so we don't see behind us anymore. It stops all that flow and it indirectly measures the left side preload. So if you look at the pulmonary artery, I inflate the balloon here. I inflate the balloon and it flattens out. Do you see that? And that's a wedge pressure. Wedge pressure. And because we know that wedge has to do with preload, we know that if the wedge is high, we have a lot of volume. Now, tamponade could be just the fact that the heart's compressed and it can't contract, and that blood's stuck in there, and it looks like it has an excess volume. It's just not moving. Okay. But most often than not, you'll see in heart failure patients, left ventricular failure, volume overload, renal failure patients, volume overload, they'll have high wedge pressures. And with high wedge pressures, they're tachycardic, they're short of breath on exertion, they have crackles, the neck veins are distended, they're up in their weight, they have an S3 or an S4, and they cannot sleep flat. So they're orthopnic. I was like, what the heck is this picture? But I get it now. T, wedge, ha. Okay. Wedge, golfing, get it? This is Stephanie's lecture, so I had to figure out what the heck that is. Okay, so what are we going to do for that increased wedge? We're going to give diuretics again, and we're going to restrict sodium and fluid. You see how this is all sort of falling into place and makes sense? On the right side, we're doing the same thing. We may need, if I'm failing, if I have a bad ejection fraction, I'm going to add those positive inotropes. Digoxin, if they're not already on it, we'll probably do dobutamine because it helps with contractility. We want to reduce afterload because we want to be able to get that blood out of the heart. The heart's kind of failing, so we don't want a lot of resistance. So you might see them on a nipride or nitropress drip. This is a potent arterial vasodilator. If we're less decompensated and a little bit more stable, we'll have them on an ACE inhibitor. Remember, they end in pril. ACE inhibitors decrease preload and afterload. ACE inhibitors decrease preload and afterload. So that's a beautiful class of drugs, or ARBs, for heart failure patients to go home on. If they're decompensated, we're putting them on a continuous IV drip of something, okay? If the wedge is decreased, it's volume again, so give them back volume. You can see the puppy taking a drink of water. Give them back volume. They're going to have all of those findings of fluid volume deficit. And one of the first things I said you're going to notice is that urine output drops. If your body's not getting the amount of volume that it needs, we stop making urine. It backs off, cuts back. So really paying attention to that hourly output is going to be crucial. Optimize again, depending on the cause. Okay. Strict INO, daily weight. Be very careful though. Like I admitted a guy that was 92 this past weekend with COVID, and he was severely volume depleted. And I was very concerned about giving him IV fluids because I didn't know how well his heart was functioning. So you as the nurse need to continually listen to the patient's lung sounds. So in case they get worse, they may be going into failure. So it's a fine line to walk, you guys. So be very, very careful. Make sure you're constantly evaluating the respiratory status and making sure that you're not overloading them. He's 92, and I think he weighed, 90 some pounds soaking wet. And I was so fearful of giving him fluids because I thought I'd throw him into failure at that point. So it's important to pay attention, take a look at their echoes, make sure that their ejection fraction can handle this. And remember, we're probably getting the NICOM parameters to see if they're going to be volume responsive if we didn't have a swan in, and we suspect their wedge is low. This is only if I have a swan in, why I ever get a wedge. Okay, but we can make those judgments with that NICOM non-invasively by guessing that the preload is low. All right, so this is your bedside monitor. I want you to see this. So, and this is a paced rhythm. This is a pacer spike. Okay. So this is your rhythm. Your rhythm's always going to be in green. This is your blood pressure. Systolic over diastolic. Look at this, mean arterial pressure. What do you guys think of that mean arterial pressure of 63? Anybody?
Isn't it low?
Yeah, it is. So I'm going to anticipate that perhaps my kidney function is going to decrease. I'm going to decrease making urine output. I'm a little concerned. Do they need volume or do they need a vasoconstrictor to bring that mean arterial pressure up? Now take a look at this pulmonary artery pressure. What do you think of that? High, low, or normal? Anybody?
It's high, right?
Yeah, it is. Heck yeah, it is. So I'm going, high pulmonary artery pressure. Take a look at that CVP. Is that high, low, normal? CVP, high, low, or normal?
High.
High.
Yeah. Okay, so what do we got going on here? So our afterload is low because our blood pressure is not good. Our pulmonary artery pressure is high, so I'm thinking, is there a lung issue? And our CVP is high, so I'm in volume excess, right?
So like, what do you think of like right-sided heart failure?
It definitely could be, but here's what's concerning is my afterload's low too, right?
Yeah.
So
It's like a valvular issue?
it definitely could be right-sided heart failure, could be pulmonary hypertension. Here's the issue. My brain says over here, I want to give diuretics. Do you guys see that? Because the CVP is high. But boy, if I give a diuretic, what am I going to do to the blood pressure? It's going to
You're gonna
drop
tank
it.
it.
So do you see the fine line of why you need to know everything? Okay. So it's definitely an issue thing that, well, we can't give volume. So now to get this blood pressure up, we're probably going to have to give a vasoconstrictor because they're already volume overloaded according to this side. Now we don't have that. Oh yeah, we do right here. What's our wedge? High, low, or normal?
The wedge is, it's low, right? 'Cause it should be
Nope.
18 to,
Nope.
It's high.
It's high.
it's high.
So now we got left-sided increased preload. We got right-sided increased preload, don't we? We got a volume issue here, don't we? And we have pressure within here, but boy, oh boy, what the hell's going on with this blood pressure? So do you see, it's not that simple to say that, oh, one number is going to give us the answer. We've got to look at everything. And really, I'd love to give a diuretic here, but boy, I'd really tank that blood pressure. So what may happen is they might add a vasoconstrictor like that norepinephrine that you guys all looked up today and give diuretics. So it's a fine line, you guys. One physician might come in and say, I want to do this. And another physician comes in and says, I want to do this. And you're like, oh my God, I don't know where to go. But you could see how conflicting that is. You think, well, the pressure should be up if my volume's up. Not always the case, you guys. Not always the case. Especially if contractility is down and I can't get that cardiac output out. I could be right here in cardiogenic shock. This could be cardiogenic shock. Okay. No one's going to ask you a test question like that. Honest to God, I'm just telling you, that's why you need to sort of look at everything and go, oh my God, what the heck's going on here?
Lorraine?
Yes.
Was 16 the wedge? I couldn't like.
Yes. So let me
Okay.
go back right here.
Okay.
Yep.
I was checking. I missed
Yep.
it.
Yep. So I wanted that picture, and it even says wedge up here. I wanted that picture to show you. This is what you'll see continuously. I've got to inflate the balloon to do this wedge. And if a patient's breathing, and remember I said end expiratory, so breathe in and exhale. We're going to measure it down here on end exhalation. Breathe in, exhale. So we want an average at end expiration. Okay.
Thank you.
All right. So we've already, this is some more of your answers to your pretest. So remember what I said, divide the heart versus right versus left. So preload, we're going to do the right atrial and the CVP on the right side, 2 to 5. And then your wedge pressure, 5 to 12 on the left side. Okay. So you fill in that little heart that I told you to fill in. And then you know, well, the right side of the heart has too much volume or the left side of the heart has too much volume. And then afterload on the right side of the heart, PVR, because we got to go to the pulmonary vasculature. And then on the left side, we got to go to the systemic left ventricular afterload, so systemic vascular resistance. Okay. And if you look here, this is my straw. This right here is my toilet paper roll. Everything's getting through. And this right here is my coffee stir. Nothing's getting through. Straw, toilet paper roll, coffee stir. Now we got to fix these two. This one's cool. We're going to leave this one alone. All right, so PVR, and we don't really do a lot with PVR except for those Viagra, those kind of things that really will decrease that pressure within the pulmonary artery. COPD causes significant cor pulmonale, if you remember that from heart failure class. cor pulmonale or that right-sided heart failure because of the COPD. I see it hand over fist all the time. They have increased pulmonary artery pressures and an increased PVR. These are calculated. Let me say this one more time. A calculated, I hit a button. Deb Phillips knows the formula. Please do not memorize this formula here. Okay, I hit a button and it gives me the PVR. So if you look at the PVR, the right ventricle is not as a strong contractor as the left. The left is the big guy. So the number is going to be higher in the left. But the right ventricle, so 50 to 250 is a normal pulmonary vascular resistance number. Increase could be because of vasoconstriction or hypoxemia or atelectasis. So I'm having issues with perfusing the lung. I'm having an issue with getting blood flow to the lung. We're going to put them on pulmonary vasodilators, Viagra, oxygen, or a calcium channel blocker. SVR. And again, don't memorize this formula unless you want to. Normal SVR is 800 to 1200. So the coffee stir is greater than 1200. So if I have a coffee stir, little thing, coffee straw, that SVR is 2800, ridiculously high. If I have a low SVR, 400, that's your toilet paper roll, okay? And we really want to be in that sweet spot of 800 to 1200. We really want to be in that sweet spot of 800 to 1200. So depending on what numbers we are, like if we have an SVR of 2800, we're going to give them medications to reduce the afterload. If our SVR is 400, we're going to give medications to increase the afterload. Okay. So I think it's on the next slide, maybe. Yeah. So causes of increased SVR: hypothermia, cardiac failure, vasoconstriction. Okay. Massive vasoconstriction for whatever reason. Okay. What do? We reduce afterload, vasodilators. And if it's a volume issue, we're going to reduce volume by diuretics. Okay. Now, there are venous vasodilators and there are arterial vasodilators. So I think we had you guys look up nitroprusside and apresyline. I hope we had you look up apresyline. That's a beautiful arterial vasodilator, apresyline or hydralazine. If the SVR is low, then we need to restore it, and we're going to use vasoconstriction meds like the Levophed that we had running today. If it's a volume issue, we're going to restore the volume as well. So we could have massive vasodilatation in anaphylactic shock because we release all of those mediators and the vessels lose their tone. Neurogenic shock, Jill's going to teach you guys in a couple weeks about neurogenic shock. And then I also see it in septic shock. We have these toxins that are released in the body that cause this massive vasodilatation. In patients that are in septic shock, I'll see an SVR of 400, and you're like, holy crap. And that's why that patient ends up on those vasoconstrictive meds. Shock, when we use that language, you guys, when I teach that shock lecture in a couple weeks, shock means I'm not perfusing and I have a low blood pressure. I'm not perfusing the body, okay? States of hypoperfusion. So we need to restore the volume if I bled out or whatever, and we need to give some vasoconstriction meds if I can't get that mean arterial pressure up to restore that tone within that vessel. Oh, sorry. And this is the only parameter, and it's a calculated parameter, and honest to God, please don't study this one either. It tells me how well the left ventricle is contracting. So we 100% want to know this. If I didn't have an echo for whatever reason, it tells me how well the left ventricle is functioning. So it's a very important parameter. The left ventricular stroke work index tells me how well the heart's contracting. So if it's decreased, I'm having failure We want to give positive inotropes like that Dobutrex or dobutamine, that's the other name, or digoxin. And if it's a volume issue, we're going to give back volume. If it's increased because I'm fluid volume excess or early heart failure, we want to unload that volume. And we unload it with the diuretics. But this left ventricular stroke work index really tells me how effectively that left ventricle, which is our major pumper of the heart, how well it's functioning. Because if that baby isn't working, we're going to fail and we'll eventually go into right-sided heart failure and everything else. So it's really important that we know that number as well. It's a calculated number. It is not anything that we would see up on the monitor while you are taking care of the patient. You have to do some math. And guess what? The monitor does it for you. All right, so finally, and then we're done, guys. Finally, it's important that you look at the trends and not an isolated reading. Remember, if you get a really wacky number, you better go back to the beginning and troubleshoot and make sure that you are calibrated, that you are level, that those are accurate readings. Question, somebody goes, oh yeah, their CVP is 70. Okay, I've never seen anybody with a 70, but maybe it's possible. Go in and get your own parameters. Go in and re-level, re-zero, do the square wave test, and make sure. Now, if somebody's fluid volume excess and you think that they have a high CVP, you should be looking for those assessment findings that match up to that high fluid volume. Neck vein distension, crackles in the lungs. They've gained 10 pounds last night. Whatever, those should match up. Always take your assessment findings, and it says right there below, assess patient, do not be fooled by normal values. And I said that about we could have a normal cardiac output and a crappy cardiac index. So looking at the whole picture, not just being paralyzed by those numbers that's up on the screen, but really looking at your patient and matching up your patient's physical exam to the numbers that you're getting. And you also want to look at the trend, not just one reading. And I always tell a story that when I was brand new to the ICU, I went to my one of my favorite nurses, Carolyn, and I said, oh my God, Carolyn, the blood pressure is 70/40. And she looks at her watch. And she said, Lorraine, it's not even 8 o'clock yet. Go back into your room, clean up your room, talk to the patient, come back to me at 8 o'clock. And I thought, well, that's not nice. And really, it was a fluky number. The patient was perfectly fine. What she was trying to tell me that was one weird number. Problem solve first before you start calling everybody into the room. Okay. So it's important to look at the whole picture and not just one number, one thing, and make sure you question those abnormal readings and level, zero, do the square wave test. Make sure those are accurate before you start calling somebody about those numbers. And that, my friends, is hemodynamics. What can I answer for you? Any questions? Yes?
How do we remember it all?
How do you remember it all? Okay, so how I remember it, I'm going to go back to this old picture. I start with this, and I really understand. I put, right atrial pressure, right ventricular. I really work with this and understand the flow first. I start with this because I'm a simple person, and I start with this. So do I understand where the catheter is, where it's ending up, what can I measure? And I like to do visual and I like hands-on, so I'd probably color this, colors or whatever to make me understand what direction the flow is, what numbers would be where. And if you look at Stephanie, she put on Canvas a diagram that has all of the parameters in there already filled in for you. But I would work with a blank one and just sort of work with it. I didn't even get into taking a whole set of parameters and looking at and telling you whether it's hypovolemic shock versus septic shock versus anaphylactic shock, which is a lecture that I'm going to actually build on from this lecture. So getting this down right now and really working with it, you're not going to know everything from leaving today. You're just not. But the more that you read it, the more that you go over it, it does make more sense. And in each lecture, like Jill will talk about, what do the parameters look like in ARDS? What do the parameters look like in renal failure? So we'll kind of build on that. So one day at a time, starting simple and understanding where we are measuring what, right versus left. I always divide the heart in half, and going from there, definitely, I think, is a great starting point. Any other questions?
When are you going to post the recording for this?
Oh my God, I got to stop recording first.
Well, I mean, like, are you going to do it tomorrow? Are you going to wait till after, like, lecture tomorrow for the Wednesday group and post it, like, Wednesday night or on Thursday?
Oh, gosh, I don't know, because you think they'll try to skip class if I post it? I'm going to post it tomorrow.
Okay, thank you.
Because I don't trust them. I don't
That's
trust them.
fair.
You guys had to show up. Any other questions? Who's ready for a nap?
I'm already laying in bed.
Oh, for God's sakes.
Maybe a beer instead.
What's
Damn,
that?
when we're on Zoom, you don't leave your bed ever.
You're
Never
kidding.
had.
Oh, who doesn't? He doesn't.
I
Damn.
don't.
Oh,
I take my notes on my computer underneath my slides, so I literally lay in bed and I never leave.
oh my God. I would never get up to class. I couldn't do it. Yeah. Any other questions? Here's the beauty of this, guys. When you guys go to clinical next week, there's an art line. You march your little butt in that room, even if it's not your patient, and you go look at that art line. There's a CVP and they're measuring right atrial pressure. You march your little butt in that room and go look at that. Okay. So getting into and looking at and touching things, and that's why I set that stuff in the lab. I was hoping that, you got your hands on things. Was that seeing in the lab helpful?
Yes.
Definitely.
I know I looked at Deb and I went, that's scary. I looked at the whole IV thing and I said, that's scary.
And we didn't even really give you a lot. Like, I've had 10 pumps. Ooh, I love all that stuff. The more the better. The more I get to mess with. I love that stuff. So
Like, once she explained them, like, each individually, I was like, okay, not so bad. Not as bad.
it's not. And again, that's why we sort of went through this process of you sitting down and looking at the medications and really doing that, because things move very fastly. You'll see nurses and you'll be like, I don't even know how they did that fast. And it's just getting you comfortable with looking at, that's what the ICU, now, don't get me wrong. There are some uncomplicated carotids that maybe have one IV, end up in CVIC and get transferred in a couple hours, or even Deb said that they get transferred home from there. So it can be very, very different in different places. What else can I answer?
So I just wanted to clarify, the only number we don't need to know is the RVP, correct?
Yeah, because that's only on insertion, Shannon. We're just looking at that waveform to see it while he's inserting, so that we say, hey doc, you're in the right ventricle. I'm going to look for PVCs and those kind of things. And recognizing it, Shannon, if the catheter has slipped back, because it should not be there. If you walk into your room, you see this big right ventricular waveform, your catheter has moved. We've got to do something about it right then and there.
Okay, thank you.
Yep. Anything else? If not, I'm giving you back a half hour. Jill said she went over, so I'm giving you back some time. Don't hesitate to ask me questions, but please look at it first before you go, can you teach that to me again? I can't. So please don't hesitate to ask if you have questions. I'll be more than happy to Zoom with you, meet with you. You just have to take it little bits at a time, okay? You're welcome. Anything else?
As far as the lines go on the actual catheters, like the arterial ones are marked red, right? For clinical.
So that the line's not marked red, this, do you see it right here?
Okay. Yep.
That'll say I hope. Again, any line that I have on my patient, I follow it with my hands and I trace it back. So I make sure that, oh, that's from the artery. Let me make sure it says over here artery.
Okay.
So we label the claw and we try to put the transducers in those spots.
Gotcha.
Yep.
Okay. Thank you.
Anything else? All right, you're free to go, you guys.
Thank you.
All right, have a great day, you guys. It was a great first day.